Funding for Yale Cancer Answers is provided by Smilo Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about signs of colorectal cancer not to ignore with Dr. Haddon Pantel. Dr. Pantel is an assistant professor of colon and rectal surgery at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Haddon, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
Sure. Well, I guess I'm originally from Vermont. That's where I went to medical school. And then I went south and did my general surgery residency in Massachusetts at the Leahy Clinic. And then I stayed there actually for an additional year of subspecialty training in colorectal surgery. So I'm board certified in general surgery and colorectal surgery. But my practice here now in Connecticut, so I keep moving one state south. My practice here in Connecticut now is just sort of GI surgery and colorectal surgery.
Terrific. So, today's show is really talking about colon and rectal cancer. And I think a lot of people have heard about colorectal cancer. It's certainly a common cancer, but maybe you can kind of paint the scene for us. How common is it? Who gets it? And who should really be aware of colorectal cancer as an issue?
All right. So it is about the third most common cancer in the United States. If you're a man or a woman, it's breast or prostate is number one, and then lung comes number two, and then colon cancer or rectal cancer, we kind of lump those together, at least for the statistics. The treatment is very different, but colon or rectal cancer comes in at number three. So it is certainly up there as far as how common it is. And because of that, I think a lot of people should be aware of it and what the signs and the symptoms are, because it's one of those diseases where we have excellent screening if you get it done. And also we have really good outcomes if we're able to treat the disease when it's early. So I think that awareness of it is really helpful, and then acting on that awareness to make sure that you're not having any of these symptoms, and also that you are getting screened and following any of those guidelines.
So let's start with screening. We've heard that colorectal cancer is really common. People should get screened. There's a few issues that I want to kind of delve into. The first is that we've heard in recent years that there are some populations, African Americans, for example, who may be more prone to developing colorectal cancer at an earlier age. Is that true? And does screening guidelines vary based on race and ethnicity, etc.?
So I think it's important to know that there's what's called average risk folks, and then there are people who are at higher risk. And what puts you at higher risk? And again, we're talking about screening, so this is people who have no symptoms at all. And hopefully we'll chat about what the symptoms are, but this is just if you're someone who thinks, well, I should be preventative or proactive about my health, and check the boxes and make sure I'm staying up to date with my health care, and that's where screening is involved. It's a different population than someone who would be having any symptoms. But the people who are at risk is family history is also a big part of it. So if you have anyone in your family, a first degree relative with a history of colon or rectal cancer, your screening should start either at age 40, or if that person had it when they were younger, you should start 10 years before their diagnosis. So say you had a brother who was diagnosed when they were 30, then you would start even sooner, because it's important to stay in front of things that may be early onset or have a hereditary component. So family history is a first big component of it. And then there's other people who are at higher risk. So people whose families form polyps, or people who themselves have inflammatory bowel disease, things like ulcerative colitis or Crohn's disease. And then last but not least, and I think this is a very small subset of patients, but there are people who are genetically predisposed to forming lots and lots of polyps. Polyps are the precursor lesion to colon cancer, and those individuals need a completely different screening setup. So There are certain high-risk populations like I talked about, and then there's sort of just the general population, which would be starting when you're 45 to get your first screening.
Okay. So it sounds like the high risk is really predicated based on family history and genetics, not so much on race and ethnicity. Is that right?
Yeah, though there are higher incidences in certain races and ethnicities as well. But those are really the sort of the ones that really are going to put you at risk. The biggest thing is family history. And, it's also one of those things that people may not bring up, when they're all getting together for Thanksgiving or something like that. It's not going to come up in conversation, at least maybe at my house, that, hey, anyone have polyps on their most recent colonoscopy? So it's one of those things that the family history may be out there, but it's one of those things that most people won't know unless they ask. Now, cancer diagnosis is different. That usually does get shared, but it's just important to know what's going on with your family, because that can have a major impact on yourself.
All right. So let's talk about people who don't have a family history or don't have any genetic predisposition. One of the things that I find happens a lot with many cancer screenings, and colorectal cancer, I think, is no different, is that there's a lot of confusion around the screening. So when should I start? How often should I have this? And in the case of colorectal cancer, with what modality should I be screened? And when should I stop? Can you kind of give us some lay of the land rules on that?
Yeah, absolutely. And I think you hit the nail right on the head. It can be confusing, and some of that is on us as a medical community, but also it's that we're trying to get better. We're trying to improve access. And so there are a lot of different screening modalities. This what I would consider the standard recommendation is that for an average risk person is that when you turn 45, you should get a colonoscopy for screening purposes. And then depending on what that shows, that's going to really determine how frequently you should go forward. So for someone who's 45 and has a normal colonoscopy, you should then be on a repeat schedule of about every 10 years. There are some things that can change that, like the degree of the prep or the clean out before the procedure. If your endoscopist wasn't able to visualize or look at the entire colon, that can change it. But if you have a complete colonoscopy at the age of 45 and they did not find anything, in the absence of any symptoms, you're going to be good until you're 55. And then if that continues, you're on a 10-year interval. You actually brought up a great point. When should you stop? And a lot of the recommendations are after you had 3 or 4, so that would be, when you're 70. When you're 75. But ultimately, I think we see a lot of people who are very functional and do have very good outcomes when they do undergo screening colonoscopies, even at later ages. So I think what I advise my own patients is I take sort of a personalized or a tailored approach to this, and that if you think you're going to be alive for 5 more years, then I think it would make sense to get something screening done. The other thing is that if you have to ask yourself, what if something was found? And if you did undergo a colonoscopy or another test that prompted a colonoscopy and a cancer was found, if you wouldn't want to have surgery for that, if you wouldn't want to intervene and you're at a stage in your life where you just like to be comfortable and that's not what your wishes are, then I wouldn't undergo any screening. It's one of those things that don't ask the question if you don't want to know the answer or if you wouldn't intervene on it. So that's sort of when I would say to stop, is really if you're otherwise healthy and you think you're going to be around for 5 more years and you'd like something done if the unfortunate event of cancer being found, then I would say to continue get screening. The other modalities, there's a lot of them. I think that the next most prevalent or maybe the other modality of screening that people are most aware of are stool-based screening tests. And there's a variety of those from what you may have seen on TV or heard of, which is Cologuard, which is a send-out test. And again, that is for pretty specific populations. And again, it's that average risk person without any symptoms without any prior inflammatory bowel disease or any family history. And that is a home-based stool test. And depending if that is negative, then you're again on a 3-year interval. If that test comes back positive, then that's what's going to prompt you for a colonoscopy to kind of confirm the diagnosis. And then there's other fecal immunohistochemistry tests, other stool-based tests, which can be combined with endoscopy, which can be done annually. The FIT test can be done annually and also combined with endoscopy for other screening. And I mean, I can really get into the weeds. There's other modalities, things like CT colonoscopy, which is an imaging test. It does still require you to do a prep. And they look at the colon as it's insufflated with air to see if anything's there. But again, I think maybe I'm painting a picture of that the waters can be slightly muddied. But I think just a simple reminder, if you're an average risk person, when you turn 45, that's when you should think about getting a screening colonoscopy.
Yeah, I think the issue for many people, and just speaking from, talking to folks, is that it's really the prep and the whole concept of, trying to clean out one's colon and then have a very long tube with a camera put up your bottom end doesn't really seem very appealing. And so the question is, while stool-based tests may not seem very appealing either, they tend to seem a little bit more appealing than the other. So are stool-based tests still okay, even if you need to have them done more frequently?
Yeah, they still are okay, and most insurances will cover them for you. Again, you really highlighted the advantages of it, which is that you don't have to do a prep, you don't need an invasive procedure, and you can do it at in the comfort of your own home. And so that's sort of what those stool-based tests offer, but they do require a little bit more frequency, and they also may not be quite as sensitive and specific as colonoscopy. With colonoscopy, you do have to do the cleanup. That's changing, and they keep coming out with additional ways of doing a prep. But still, none of them are pleasant. But they're getting more tolerable. And you do have to go to an endoscopy suite and have the procedure done. I think the one thing about colonoscopy, and it's actually I think pretty unique to almost any of our cancer screening modalities, is that yes, it is a screening test, but it also has the potential, if something is found, to be preventative. And so the advantage of a colonoscopy is that a polyp, which is a precursor to a cancer, can be removed at the time of the procedure, and you can prevent it from ever progressing or growing into a cancer. So it really is, yes, a screening test, but also it has potential to be preventative as well, which I think is pretty unique among all screening modalities across cancer, at least that I can come up with off the top of my head.
Yeah, no, certainly. If you can have a test that can find a potential precancer and remove it, and you're kind of done all in one shot, that certainly has its advantages as well. Right now, we need to take a quick short break for a medical minute. Please stay tuned to learn more about the care of patients with colorectal cancer and symptoms people should be aware of with my guest, Dr. Haddon Pantel.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where all patients have access to cutting-edge clinical trials at several convenient locations throughout the region. To learn more, visit smilowcancerhospital.org. Over 230,000 Americans will be diagnosed with lung cancer this year, and in Connecticut alone, there will be over 2,700 new cases. More than 85% of lung cancer diagnoses are related to smoking, and quitting even after decades of use can significantly reduce your risk of developing lung cancer. Each day, patients with lung cancer are surviving thanks to increased access to advanced therapies and specialized care. New treatment options and surgical techniques are giving lung cancer survivors more hope than they have ever had before. Clinical trials are currently underway at federally designated comprehensive cancer centers. such as the Battle 2 trial at Yale Cancer Center and Smilow Cancer Hospital, to learn if a drug or combination of drugs based on personal biomarkers can help to control non-small cell lung cancer. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anise Chagpar, and I'm joined tonight by my guest, Dr. Haddon Pantel. We're talking about colorectal cancer, and right before the break, we were talking a lot about screening for asymptomatic people, whether you're at high risk or average risk. But Haddon, I want to get into the whole concept of the fact that, well, some people may not be asymptomatic. So to begin with, can you kind of give us a breakdown? What proportion of patients that you see come to you after being diagnosed with colorectal cancer after having symptoms versus having had their cancer picked up by a screening test?
I think that's a great question. It's pretty nuanced because a lot of times people will undergo a screening test and sort of think they're asymptomatic. And then when they get the diagnosis of the cancer, they'll say, I haven't been feeling right for a while. Maybe they've been having more constipation or more loose bowel movements, or maybe they had noticed some blood when they went to the bathroom, which they chalked up to maybe it's just a hemorrhoid or something like that. And so there can be a lot of what I would say is recall bias. And when people get a diagnosis, they sort of start to reflect on the last couple months to maybe even year, and sometimes things do get picked up that way. So it's also a little challenging because a lot of patients, when they're sent to me, are having symptoms and don't even have a diagnosis at that time. So we sort of have to make sure that they've gone through all the appropriate steps to rule out something like a cancer as the cause of their symptoms.
So let's dive into what those symptoms are that people should be thinking about. Now, you mentioned a few of them. Talk a little bit more about what are the symptoms and for how long should people have had those symptoms before they come to their doctor to have that checked out. I mean, certainly they don't want to be coming to their doctor every time they may have diarrhea after a night of really bad Chinese food, right? So at what point should people be thinking about these symptoms and seeking medical attention?
I think one of the hard things is the symptoms, there's a lot of overlap with other, processes. Like you said, it could be just some food you ate. It could be something like a hemorrhoid. But usually the symptoms, if there are any, would be blood in the bowel movements. That'll be, could be bright red, almost like you cut yourself. And that indicates that the cancer or the tumor is lower down in the GI tract. The blood is making its way all the way out. But sometimes people can have more dark or tarry stools. They'll say it looks like asphalt. And that just indicates that the cancer is higher up in the GI tract. And so that blood is getting broken down by the bacteria in the colon. And it's sort of changing from that bright red blood we associate with a cut to something that looks like dark or tarry stools. So those are common ones. The other thing is that it's going to be nonspecific and just changes in your bowel movements, whether that's going more often or going less, so constipation or more frequent bowel movements, or changes in the stool consistency, either more loose or sometimes it may be even more narrow in caliber. As if you have those symptoms and you do meet the criteria for screening, I would say you could check that box anyway, meaning if you're over the age of 45 and you're having them, well, it may not the cause of those symptoms very, very likely is not going to be a cancer, but I think it's a way that you should make sure that you've checked the box and you've kind of ruled that out. So if you're of the appropriate age, I would say as soon as you have those symptoms or if you have them to get screened.
And so, so presumably, let's say somebody has had a change in bowel habit. Maybe they've been having some blood in the stool and it's been going on for a couple of weeks and they're getting a little bit concerned. So is their first stop their family doctor? And what happens at that point? What tests should they anticipate? Would the first step be a colonoscopy?
I think it is always a good first stop to start with your family physician. They can sort of triage you and check for symptoms again that would be red flags, pointing again towards a cancer, or those that aren't. Usually, if you are going to go down the route of ruling out a cancer, then yes, the answer is a colonoscopy, because then you've sort of, if you're having bleeding or any of those symptoms, usually you're outside of the screening. You're sort of not in that screening box, and now the colonoscopy switches to a diagnostic or maybe even, depending on how much bleeding, even potentially a therapeutic procedure. So that is the next step. Oftentimes they may check some blood counts to see if you're anemic as well, which can be another marker of colon cancer. But colonoscopy is the really surefire only way to make a true diagnosis. People often inquire, well, I've had a CT scan for X, Y, and Z, recently. How come that didn't pick it up, or wouldn't that be sufficient? And if CT scan could, we certainly would be doing that as opposed to, endoscopy or colonoscopy. So that is the test that they will, if they think that this is warranted, that they'll order. And usually that involves a referral to a gastroenterologist or sometimes a surgeon to be arranged for a colonoscopy.
You had mentioned when we were talking about screening that colonoscopies could be therapeutic, but are they always? For example, let's suppose somebody has a colonoscopy and there was more than a polyp. At what point are things treatable with colonoscopy alone? And at what point do you then require something more, like a surgery?
Yeah. So oftentimes, colonoscopies find polyps, usually in about 1 in 4 average risk people, and those can be removed right then and there in that same sitting. So it's, like I said, both screening and it can be therapeutic and preventative. When the diagnosis of an invasive cancer is made, that is when a referral to a surgeon is placed. And what that means is, a polyp is just an error in growth of the lining of the colon. As the cells in the lining of the colon divide and divide and divide, it's almost like you have a piece of paper that you keep transcribing by hand. If you make enough copies, you may misspell a word here or there. Now, over 10,000 or 10 million times, right, those little mistakes get copied and amplified. It's almost like a game of telephone. And that's what goes from from normal to polyp, and then again, enough of those mutations or changes accumulate, and that's when you have an invasive cancer. And that means those cells that have sort of changed a little bit have gone through the lining of the colon and actually into the deeper layers, like the muscular layers and the lining layers, and that is when surgery is involved.
And so in order to make that diagnosis of invasive cancer, how does that actually happen? Is that a biopsy at the time of the colonoscopy? And then what happens?
Yeah, so the steps that need to get done, so colonoscopy makes a diagnosis, and yes, a biopsy is taken at that point in time, and actually the endoscopist will also mark or locate where the tumor is exactly in the colon with injecting a little bit of ink, India ink, like you'd use for a tattoo. So that lesion can be localized at the time of surgery. So step 1 is confirming the diagnosis and localizing the tumor, which is all done in that setting of the colonoscopy. Once that's done, then the biggest step in treating colon cancer or rectal cancer is determining, is the disease local? Is it just to the bowel, or has it spread to things like the liver or the lungs? And we answer that question by getting a CT scan. So once people have made the diagnosis of colon cancer, then they get a CT of their chest, abdomen, and pelvis to make sure that things are local or not, meaning spread to the liver or the lungs. And that's a big split because the treatment is vastly different. Usually people who have disease or cancer that has spread throughout their body, the initial steps, and I do say initial because there are some surgical options too, but the initial steps usually start with treating them throughout their whole body. So systemic disease usually equates to systemic treatment, which are things like chemotherapy. However, local disease, meaning the tumor is just confined, the cancer, is defined just to the bowel or maybe the lymph nodes, that is treated with local therapy. So local disease gets local therapy, and that's where surgery is involved.
And so what's the breakdown there? I mean, for people who have had symptoms, they go, they get a colonoscopy, they have a biopsy, it shows invasive disease. And you go on and you do that staging workup with the CT. If a patient was to ask you, Doc, what's the probability that I'm going to have metastatic disease at the time of presentation versus this being localized? Because really, I'd rather have the localized than the metastatic. What's kind of the breakdown there? And how does that translate into prognosis?
Yeah, so I get asked that question all the time. And I actually don't answer it because I really think it's an individualized. The statistics are there, and they do also are influenced by interval between last colonoscopy or maybe never, and also degree of symptoms. So the statistics are there, but really it's just a case by case basis. If you have metastatic disease, you have it, and if you don't, you don't. And so. It's yes, you can say 20, 25%, but you can also say it's 0 or 100, right? And so it really is almost dichotomous or a split. So that is sort of my approach to it, is that a patient who comes sees you in the office is that they're a person, they're an individual, they're not a statistic. So we give people those answers. A lot of people come in and they say, well, what stage am I? And really the main split is, are you stage 4, which is metastatic, or not? And 4, and then it's 1, 2, and 3. And that difference between 1, 2, and 3, we answer that question after surgery when we've removed the tumor and all of the lymph nodes that are with it, and we can get a sense of, have things just been confined to the wall of the bowel a little bit farther out, or into any lymph nodes. Okay.
So let's look at those two groups. For the metastatic group, you mentioned that they've got systemic disease. They'll need systemic treatment, usually with chemotherapy. Is that right?
That is, stage 4 metastatic colon cancer is a very heterogeneous population. It can be people who have spread to both lobes of their lungs, both lobes of their liver, disease throughout their abdomen, which can be, the intent to cure that person is not there, but it can also include, and does include, people who may just have a small liver lesion or something that is treatable in the liver or the lungs. So both people would be considered stage 4. The intent can be very different. And so I think it really highlights actually the importance of having a multidisciplinary evaluation. So if you are in the unfortunate situation that you do have stage 4 colon cancer, metastatic colon cancer, the benefit of seeing a multidisciplinary team is that you can have evaluation from a medical oncologist who would be weighing your chemotherapy options, a surgical oncologist who may be able to evaluate you for, is there local options for liver disease, and a colorectal surgeon who can give you options for treatment of the primary tumor. And there are nuances in the order which those things are done, how much chemotherapy, timing of surgery, and things like that. So, stage 4 is a very diverse group of patients, and because of that, I think it's good to have diverse opinions and diverse options so that you can get the best care possible.
Dr. Haddon Pantel is an assistant professor of colon and rectal surgery at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.